So we'll move straight on to the first topic, which is the psychological aspects of diabetes study meeting that you both went to recently in Romania. Are you able to share any of the outcomes or presentations that you attended at the conference with the community?
Who's going to go first, Mark? You or me?
I'll let you, Ken.
Okay. I think we could actually probably tell you all about it, but my problem is seniors' memory is about, I can't remember what I said about 5 seconds ago. It was probably one of the best conferences I've ever actually been to. Listening to how the psychosociology, and I can never say that word, but basically psychology affects our diabetes, and it doesn't matter what type it is. I concentrated probably more on the type 2 for obvious reasons, because there was basically 2 streams, type 1 and type 2. The streams I concentrated on were stigma and also cardiovascular disease, which we'll probably talk about later. But listening to the researchers, some of them quite young. But there you go. I must be getting old if they're young. They're quite young, and yeah, they were very good. They brought out things that probably we all know about, but sometimes frightened to say. I think it's probably a bit the best way to explain it. On the cardiovascular disease, I learned something which I thought was very profound, actually, where if you have cardiovascular disease, you tend to worry more about that than your diabetes. Even though the diabetes is partly responsible for the cardiovascular disease. So it's, yeah, it was an interesting thing. There was far too many presentations to even go through them. Literally hundreds of them. All very good, and I'm sure Mark will agree with me there. If you really want to see the photographs and everything else, speak to Mark. He did every single one of them. It was you, Mark.
Well, I unfortunately, since there was 2 streams, I couldn't attend all of the sessions. But I certainly, I'm still making my way through the 1,250 photos that I took while I was there. But the thing that struck me was that there was something of the order of 65 people from 23 countries there. And it's very much a collegiate atmosphere. You had very senior researchers, you had PhD students there as well. And each talk was allotted a slot of 15 minutes, and the person or people would speak for 5 to 10 minutes, and then there would be questions asked for the rest of the time. And the fascinating thing was it wasn't only the audience asking questions of the researcher. Sometimes the researcher would ask the audience what they thought they should do in regard to something or ideas. And yeah, it was a very collegiate atmosphere, like they were all colleagues. So you had senior researchers with 30, 40 years experience giving advice to the PhD students, for instance. And it was just such a great atmosphere. Ken, I don't know if you'd agree with that.
Yeah, totally. I remarked to Jane Spate, who is the chair. I said, this is about the only conference where people with lived experience can say things, and you don't get the but afterwards. What I mean by that is that if you go to various other comments like ease or other things, where the clinical people speak, in a sense, or healthcare professionals. Sorry, Claire. But they say, you say something and they say, but we do this, and but we do that. We didn't get that. They listened to understand rather than to reply, which I found very refreshing. I don't know, how did you notice that, Mark?
Yes, very much so. I mean, for me, the breakouts and the tea breaks and lunches and dinners were as valuable as the sessions, because we had lots. Oh, I don't know about you, but I certainly had lots of good quality conversations in those breaks. And I spent quite a bit of time speaking to a lady who's just getting into the diabetes field, but all of her research in the past has been in other areas or around type 1, and she told me that she learnt a lot just by listening to me talk and relating my experiences, and she asked questions, and of course I answered them. So yeah, I think it was absolutely appropriate that we were there, and I think like we both added a lot to the discussions that were had.
Yeah, absolutely. Yeah.
One of the big things was, or the sessions that I got a lot out of, was about the de-stress program. This is for a couple of methods of reducing stress. The current program is focused on type 1 diabetes, and it's currently being evaluated, and it's working on working with healthcare professionals and training them up to how to consider the psychological aspects when they have their meetings with their the people with diabetes. There is talk of extending it to type 2, but that isn't moving anywhere just yet. But yeah, it was great. The other thing I found really interesting was a talk from an Australian lady. She did an evaluation of a public information campaign in Australia around diabetes stigma. And the conclusion that she came to was that some of it was great, but they also felt that it would actually, in some ways, making the stigma worse among non-diabetics. So it was a fascinating talk, and just the idea that a campaign to reduce stigma could actually make it worse was interesting, and shows how careful such campaigns are going to need to be, because it's certainly something I'd like to see in the UK, but it did give me pause to think, be careful what I wish for and make sure it's done right, as it were. So yeah.
Yeah, I totally agree. I think the thing I kind of wanted afterwards was thinking that it's how do we, as people with diabetes, deal with stigma? What do we do? How do we do it? How can we counteract it, in a sense? Because if you're newly diagnosed, etc., and you get this stigma coming at you right, left, and centre, there's no help in how to counteract that, and that, I think, is probably why people with type 2 tend to hide away, because of the shame and the guilt. But these are just some thoughts that were going through my head. I don't know what anybody else thinks.
I was thinking, sorry, Mark.
No, continue.
I was thinking that a lot of the information that you see on social media and in the press on type 2 diabetes, it's all about prevention and being able to put your type 2 into remission. But that adds to the stigma of people thinking, oh, I've got type 2 and I'm to blame. I don't know whether anybody else shares that same feeling.
It's something I've thought about a lot, and it's only really been in the last year through talking to people at Diabetes UK, on the stigma panel, that I have really come to understand the realities of it. Diabetes, type 2, even if you just consider it in isolation, is a really complex condition. There are multiple causes, multiple interactions, and blaming someone. All right, there's 2 points. Number one, although diet and exercise can help your diabetes, a lack of those isn't the cause.
Yeah, totally.
Yeah, it's an interesting distinction, but it's one that not enough people make. And the other thing to remember, and I hang on about this one, is that nobody deliberately makes a bad decision. Everybody's doing the best they can at the time with the knowledge and resources they have.
Yeah,
So
100%. I think we've said that before, though, haven't we, on many a chat?
yeah, and if you blame someone for doing the best they can that they're able to do at that point, then you are being needlessly cruel and ignorant. That might be considered strong language, but it's how I feel about it. And one of the worst groups for it is, I'm sorry, Claire, is the healthcare professionals.
That's all right. You can count me out of a healthcare professional at the moment because I'm not practicing.
Fair enough. It's there is a Latin phrase, prima non sociere, which roughly translates, and excuse my pronunciation, any Latin scholars, but it translates to first do no harm. And that's one of the things that medical students are taught when they, in their very first year. And it's a guiding theme in their training. Well, I can tell you that if you are stigmatizing a diabetic, then you are failing at that. So, yeah, I'll have to get off my soapbox because this is one of my hot button topics. But yeah, if the doctors need to collaborate with their patients, and if they want to build rapport to be able to do that, then the psychosocial aspects of diabetes are of paramount importance. As I said in one of the sessions at the meeting, the most important question a doctor can ask when first speaking to a patient in their checkup meeting is, how do you feel about your diabetes? Giving the patient the chance to express their feelings and explore that topic is going to build rapport. It's going to inform the doctor about the person's concerns and make the entire meeting go a lot more smoothly. But it doesn't happen, or at least it doesn't happen as often as it could. Sorry, I feel like I'm dominating the conversation at this point, so I'll shut up and let other people express their opinions.
I think everybody's got the same opinion. Ken, have you got anything to add to that?
No, I think he's Mark has hit the nail on the head in the sense. The problem, I think, and it's not just in the UK, it's worldwide, is the psychological aspects of having diabetes, any type, and how it can actually affect you. And just listening to your preamble was interesting to hear, what Tom was saying, and how various things can screw you up, as one might say in a good psychological term. But we need people that can help people through the psychological aspect. And he doesn't have to be a psychologist. They can be a counselor, can be a psychotherapist, who do the same thing. And a lot of people mix up psychology and psychotherapists as the same, but we're slightly different in a big way. Unless they're trained in psychotherapy, psychologists can't really help people with problems. They can help everybody else understand the problem, but they can't help them. So they need to be trained in some sort of counselling technique. Yeah, I think we'll probably done this to death for about 10 million times. But will it ever go away? Probably not. But we will need to keep hammering on about it, unfortunately, until the time comes when it becomes less of a norm and more of something that happens occasionally.
Yeah, I think one of the ways that we can do that is by sticking together and talking about what we need to talk about to get people to recognise that people with diabetes need help, not blame and made to feel guilty.
Yeah, it's the support that we need, and I'll change the subject slightly, but it does give the same sort of feeling. At a board meeting, I said, people, as probably some of you know, as a peer support group, where they are saying to me is that they can't get support from their GPs and everything else because they have to make an appointment. And, if you're not getting that support, how do you trust your GP? How do you trust your diabetic nurse if they won't speak to you?
Yeah, 100%. I mean, that was what my next question was actually going to be, but you've already answered it. But the part of it, do any of you know of any good resources for mental health support?
Yeah, me. Sorry. Joking apart. There are various things online. There's things called for CBT, cognitive behavioral therapy programs, which you can actually take part in. But CBT is not for everybody. Unfortunately, the NHS the waiting list is months. You may have to go privately. But what I do say to people is that if you don't feel that you're getting on well with your therapist, change therapist. You are allowed to do that. There's no reason why you don't stay with somebody all the time. So, be mindful there are people out there that can actually help. But sometimes, unfortunately, we have to pay.
Yeah, that's the problem, isn't it, at times? But hopefully in the future, maybe they'll be more available on the NHS. Mark, have you got anything to add to that?
Not really. Ken knows a lot more about this area than I do, so I will defer to his expertise.
I don't know about the expertise, but yeah. Kind of semi-retired these days, Mark. But yeah, it's being I feel tremendous that we really do need therapists out there that can work. And as I said, it doesn't have to be CBT, although the NHS loves CBT. To me, it doesn't always work. I don't. I do CBT, I do REBT, I do NLP, I do all the anagrams that you ever want to know about, but I use as and when necessary in the sessions. And it's getting that right person for you as somebody with the problem. And actually, the best people are actually a peer support group, people that are actually going through it now. And just talking to one another, listening to one another without any, oh, but, no, but, yeah, but, whatever, but. It's just listening sometimes is all that people need. And that, to me, is probably the best therapy you can probably have. And that's free. So.
It's, I would completely agree with that, Ken. I mean, you cannot overemphasize the importance of being heard or feeling that you are heard. And that actually applies in going and speaking to the GPs and the DSNs as well. Too often they're talking at you, not with you. And half the other issue is that they're attempting to have a rational, numbers-based conversation, but the person with diabetes is just as likely to be having an emotional conversation or wanting to have an emotional conversation and not being listened to. If the de-stress program gets rolled out, hopefully that might start to change, because that's one of the aims, is to get the GPs and nurses to be prepared to have emotional conversations around diabetes with their patients. But I'd imagine we'll see that for at least several years. So
yeah, there is a leaflet, a questionnaire that psychologists and psychotherapists can actually use for diabetes. I've never used it because it is very much a tick box exercise, and whereas our emotions are not tick box.
No, definitely not.
True.
So it needs to be a much more. I like what somebody once did or said to me years ago about. So this is about obesity, but it can be used for any type of problem, NCD. Is you fill out a little form or tick box on what would you like to talk about today, or you could write something down, and you could hand that to your GP, your DSN, so that it gives them the in to talk about it, or at least be able to signpost you to the right place. And I don't think we do that enough. What I try and tell people is when you're going to see your GP or your DSN or anybody in the healthcare profession, write down your questions and hand it to them. Because then they have to actually put that on your records. So it gives them a starting point of where you're actually at. And it's a bit like what Mark said at the beginning there. How are you dealing with your diabetes today, almost? But it's a starting point, and I think that is what we need, is that starting point. And if you don't have a starting point, then they're going to go on about HbA1cs, they're going to talk about your cholesterol, you're going to talk about this, they're going to talk about that, whereas you want to talk about something else. So write it down. It doesn't have to be perfect English. I mean, have you seen doctors' writings lately? Yeah.
I haven't seen doctors writing, but I've seen my diabetic nurses writing.
Yeah. Sorry, I'm being flippant there, but you know what I mean.
We do.
Definitely. Which leads me on to my next question, as you've both recently been to a conference. Are either of you planning on going to any more in the near future? And do you have any advice you would give to anyone who wants to attend any diabetes conferences?
Join DDoc.
Yes, I would. Yeah, look, DDoc is the biggest scholarship program in the world for people to attend diabetes conferences, and they are always trying to get new people in and to conferences. I'm hoping to go to EASD again this year with DDoc, but wait and see on that. And yeah, but yeah, join DDoc. It's the easiest way to do it. And even if they can't get you into a conference, they can probably give you advice on it anyway. In fact, I think, can they do DDoc videos on going to conferences?
Sometimes there's a hybrid for conference ESD. We didn't have one for the Diabetes UK one.
Yeah.
Yeah, ESD is probably the big one, but if you can pay your way there and your hotel bill, then the DDoc will find you a way in to the actual conference for free. But that can be expensive because the hotels tend to be shoot up their prices very much. So when they realize there's a huge conference in town. The next one is ESD is in actually Vienna. There is a Sigma one. I'm going back to Sigma again in India in at the end of this year. I can tell you the date, but I can't. Otherwise, you'd have to shoot me. But shall we say it's around about November, which anybody can go to. It's what I find really annoying in a sense is we don't get any grants available for people for diabetes advocates apart from DDoc. I know that somebody was telling me that the Australian lot have lots of grants for people to attend conferences. So why can't we do something similar in this country? Especially the pharma companies and everything else. It would be nice to have some sort of grant system for people with that are advocating diabetes to attend conferences. What do you think?
I think it's a wonderful idea.
Yeah, I was going to say that sounds a wonderful idea.
I think it's a great idea. The only problem is definitely in Britain you have all those, and I know Germany has it as well. There are certain things that they don't like. Big pharma talking to patients. I went to DUK 24. I've unfortunately not been granted any DDoc scholarships this year, which was annoying because there was a conference. There was a session on type 1 obesity, which I really wanted to go to at ATTD. But don't be sad as always. But the problem is in the UK, especially, you can't have patients, and I think especially with the diabetes community, definitely type 1. But as you guys start coming into it, they need to look at those ethics because I don't think it's. I can understand they don't want what happens in America, and ask your doctor for Nova Rapid, but we already do. We already talk about how the different insulins work, and I think that there's a big load of medical ethics, which would have to be overcome. And I do think that if you think about lived experience in some ways as type 1 as the 101 for people, peer support, the next thing that people want to know is what's going on and how can we make our our conditions better. And maybe that's something for Diabetes UK, Breakthrough T1D, and everything else to look at, that maybe there now needs to be that next step. Does that make sense? Because unfortunately, DDoC can't afford to send out all of us to conferences. I know that when at TAD last year, they had somebody from the Grand Challenge, and they were, that got well received. So one would hope, and I think they've done something online recently with it as well, with the Grand Challenge. But one would hope that there could be more for us to sort of like contribute. And I suppose I need to fill in for the lived experience panel on DUK, because I've always been JDRF tip breakthrough. So growing up, I hardly ever heard from them. I think about in the first 20 years of my diabetes, I got a key ring, and that was about it. But that's going back into the 80s and 90s and early noughties. But anyway, that's just my thoughts, and I can rant and ramble on this. But I do think for those of us who want it, there needs to be more avenues.
Yeah.
Unfortunately, they are trying to get more new people. So those of us who've had another one go, unfortunately, are having to wait and only get one go.
There is a way around it where the pot comes into a central place, so it doesn't matter where it's coming from. And that group of people, and it could be anybody, we do, a board that decide how to give out grants, and the money is not necessarily from any particular company, but it's a mixture of all of them. So that could be a way around it. It's my thing is, we can't do this because of that. So how can we get around it, and how can we do it?
Yeah, I know Partha, when I was there in 2024, he was trying to find ways around it. It was like, because I took a lot of the photography for 2024 with DDoC, and I did a group picture with everybody and Partha, and it was like, oh, there's a Sanofi sign in the background, and there was a lot of worry about that and stuff. And it's just, I think that all needs to be looked at with the pharmacy, or whatever they're called, the ethics committee, because it's just, I know why they do it, but it's just taking a sledgehammer to crack a nut, which is not needed in type 1, because there's things I would love to be able to share, but that's the way. And I know when I went to stalls at DDoC, at Diabetes UK 24, oh, you've got a press pass, we can't really speak to you, and stuff like that. And it was just so, but that's just me. I'm another ranter, so I better stop.
No, don't worry about it. I mean, it doesn't matter whether it's type 1 or type 2. You're really not alone in that feeling. And I think, I certainly know that Mark has that same idea as well.
Yeah, I mean, it is something that, yeah. Anyway, have to wait and see. If you want to hear me more rant, my TikTok will soon be up, the Diabetic Comrade, and you can enjoy it there, which will be where I'll be ranting soon.
Okay.
Philippa, you've got your hand up. Did you want to ask something or say something?
Yeah, and this is, I suppose, my opinion. I think I agree with what you're saying about attending conferences, and actually, I think that's what DDoC do, because it's not DDoC's money that sends us there; it's pharma companies and the tech companies that send us there. But I do think there should be more of an onus on people actually sharing their experiences. Because I know I've said this before, we've got more people physically on the ground at conferences who live with different types of diabetes. But I have to be honest, on my social media, so unless I'm following the wrong things or whatever, but I've searched hashtags and etc., there is so little fed back. And so it does make me wonder that when DUK used to do it, that they had 4 people going, I could guarantee those 4 people will be at the top of the social media, you know, sort of how much they'd posted and retweets and stuff like that. I don't believe that's the case now.
Yeah, I mean, that's why I set up. I actually on Blue Sky set up special feeds for hashtag T1D, hashtag GBDoc, and hashtag DDoc, and there nothing really comes. And I think the problem is, well, it's not a problem. It's the way it works. People curate their scholarship in the way that they are. They feel most comfortable. Some people will not like to live tweet. I love to do that, and
but they need to put something at some point. I'm not expecting everybody to live tweet. Do not get me wrong.
mm-hmm.
You know, I don't always live tweet either, but to put something out, you know, it's just a personal opinion.
Yeah.
So others might disagree, and it may be like I don't really use Instagram, and maybe everybody's on Instagram, and that's where it was all going on. But from the other platforms, there's so little, and it's not that I particularly see blog posts or stuff like that coming out that are spread around either.
Yeah, I kind of agree with you. I can't do listen and tweet at the same time. My dyslexia gets in the way. But,
it's difficult, particularly if it's a new subject. If it's a subject, and if I'm honest, I can do it if it's a subject I already know bits about, because you're just learning add-ons.
Yeah,
So you if it's really technical, I can't do it at the same time because I then miss out the next bit. But it's not that, it's just generally, I know there's like 20 odd people at these conferences, and I maybe read, there's one person who was really, I don't think they were a physical attendee, but online, who did a lot. There were a couple of people who did, but the rest didn't hear a dicky bird.
Yeah, there are quite a few others. Remember, it's an international, and sometimes it'll be in other people's languages, unfortunately, and they may not do hashtag diabetes or whatever. So it's knowing who the people are and following them, I think, is probably the best way to do that, because I have read quite a few accounts, and there's a young lad, I can't pronounce this, Tinadiki or whatever his name is, who actually does a lot of live talking and chats to various people at the conference as well. So there's there is information out there. I mean, I did put a lot of photographs out, and Mark, when he gets through his 10,000 photographs, we'll probably do a lot more with PSAT. But it's sometimes you're ready to do a quick picture and they change the slide that you were trying to do, which is annoying.
Oh, I'm not having a personal go at anyone. No. Please do not take it that way.
No. I'm the lazy blogger, I'm afraid.
But it is just, there's so many more there. Yeah, actually, there's less information being shared with the community.
I agree with you. I think there is less and less, and especially of all types of diabetes, not just type 2, but certainly all types. So we need to buck up our tread. But then,
maybe it's that when they're choosing people. Sorry, I'm eating at the moment, so.
Yeah.
But they actually say, how are you going to share it? And I'm not saying everybody has to share on social media or whatever, there'll be other pathways, but you make sure that there are some people you know are going to put out content on the day. Maybe say, okay, you're not obliged to do a blog afterwards or whatever, but we're relying on you to, do you know what I mean? Update social media.
Yeah. What gets me, and I think this is where we need to work on social media and everything else, is people will like somebody saying something instead of reposting it.
Yeah.
If you like it, it doesn't go anywhere. If you repost it, it goes somewhere into your groups.
I always repost.
Yeah, you must repost. If you just like it, then it isn't you're not doing anything. So I trying to repost as much that I think is useful to the diabetes community, not just for my people, but people that know me and various other things. So learn the ethics of social media so that other people will follow. And that's the trouble. People just, oh, I like it. We're full of likes. That's how many likes we get. It's not likes. It's about information getting over to everybody else. Sorry, I'm going to shut up. I'll let Mark speak. He hasn't said a word for about half an hour.
No, I think I've said enough, but certainly I think there can be more going out on social media, although there is a fair bit. But yeah, you're right. It's something we need to do, and certainly reposting and resharing stuff. You know, when you're on, well, my two main channels are LinkedIn and Facebook, and I am forever sharing stuff or reposting either with or without my comments on both those platforms. Simply because, you know, my followers are not necessarily the same as the person who originally posted it. So it's getting it to a wider audience, which is, you know, often very important. Particularly stuff around stigma. It's just such a big issue.
I totally agree with that. It definitely is such a big issue.
Yeah.
I think we could sit here and talk about stigma all night, but I'm conscious that it's 9:15 and we haven't even started on really the main topic yet.
I think we better go there then.
Okay, well, we thought we'd talk a bit about different medications that people who have been diagnosed with type 2 are prescribed. I know most people are aware of drugs such as metformin and glycoside, but I thought we'd touch on GLP-1 receptor agonists tonight. We do advise anybody who's listening on the call, who's watching on YouTube, or who listens back to this, that if you have any queries with your medication or your treatment, to go and talk to your healthcare professionals or your diabetes team, because we are not healthcare professionals. Our guests are just giving their lived experiences of the medication or treatment that they are on. So, GLP-1 receptor agonists are a class of medications used primarily to treat type 2 diabetes, though some formulations are also approved for the treatment of overweight and obesity. They have many benefits besides weight loss. They can help improve blood sugar control, reduce the risk of cardiovascular events such as heart attacks, strokes, and death from coronary heart disease. They can also help improve lipid disorders, help with fatty liver disease, and reduce the risk of kidney disease. Mark, I believe you've been prescribed one of these medications. Would you like to give a bit about your experience of being on this medication and share it with the
Okay.
community?
All right. I was in December last year. I was put on tirzepatide, which is the drug name. The brand name in the UK is Mounjaro. So most people probably know it better by that. It's got a GLP-1 receptor agonist and another agonist as well, so it's a dual agonist medication. I have had a stent fitted as well, plus atrial fibrillation, which is, and I think those two things were part of the reason why I was able to get put on it. And also my BMI was a fraction over 35 at the time. I love the stuff. It's the first thing I would say. It's significantly improved my control of my diabetes, to the point where I'm now hitting 100% time in range on my glucose sensor, which is, unheard of. I think the fact that I'm on a low carb diet ties in nicely with the Manjaro, because if I eat a lot of carbs, my insulin, my glucose level still shoots up. Don't get me wrong, but I don't generally eat that much carbohydrate anyway, so it's helping me keep my levels in range, and it is suppressing my appetite. There are side effects. For me, I can quite frequently suffer from a loose tongue, to put it politely, and that's an issue. But my insulin usage, I was on 40 units of Levemir, a long-acting insulin, and about 80 units of short-acting insulin a day before I started on the Manjaro. I'm currently on 15 units of long-acting and between 0 and about 10 units of short-acting a day. There are some days I don't take any short-acting insulin at all. And as of 2 days ago, I had lost over 10 kilos in 6 months. My target is 20 kilos or thereabouts, and I'm now more than halfway there. So I'm pretty pleased with that. It definitely suppresses your appetite, and I have to, in some cases I have to force myself to eat, because I know there is a limit to how low I want my food consumption to go. I tend to have a high protein diet anyway, because lack of protein and muscle wastage, because you're not getting enough protein in, can be an issue on these drugs. But I tend to eat a lot of protein anyway, so it's not such an issue for me. Yeah, like I say, I love the stuff, but I'm certain that it isn't for everybody, and it is not a miracle cure. The fact, as I said, the fact that I'm on a low carb diet is helping me hugely. I think because the increase in insulin sensitivity that the Manjaro is mediating means that with a low carb diet, I need far less injections to keep me in range. So yeah, don't know what else I can say really, but that's my
Thank you
experience.
for sharing that, Mark. Ken, do you have any experience with GLP-1s, or are you just on insulin?
I'm just on insulin. I probably should be on Manjaro, but these days I think I put too much weight on recently. But I wouldn't get it where I am at this moment in time, because they don't give it out right, left, and centre. Tom's got his hand up. Sorry, Tom.
Yeah.
Okay. I'll let Mark speak first.
Okay. Right. Having been to conferences, I first asked about this late in 2023. And I specifically asked about tirzepatide because, or Manjaro if you prefer, because I'd seen the literature about the incredible results people were getting with it. And I thought to myself, I want me some of that if I can get it. Now, there's a few things to say here. Number one, because I was initially, back in 1996, misdiagnosed as type 1, not type 2, I was put on insulin, and I was put on long-acting insulin. So when I moved to the UK, I was put on the same drugs as I was already on. Now, the only reason I know that I was misdiagnosed as type 1 is that I don't give type 2s long-acting insulin, Levemir in my case. Because of that official confusion, I was sent off to see the endocrinologist at the local hospital. And I have continued to see her like once a year for the last several years. It was only that official confusion that enabled me to get CGM as a type 2. But the endocrinologist saw the results I was getting from using CGM and she agreed to fund it. And she kept seeing me. Now, initially, she said, no, you can't have Mounjaro because you have diabetic retinopathy. I was lucky enough at Diabetes UK conference last year to find out about the Noctura 400 mask, which is used for treating diabetic retinopathy. As a result of that, October last year, I went and saw the ophthalmologist, and he looked at my eyes and said, "They're perfect. You've got no more weak blood vessels and no bleeds. I'm releasing you back to general screening." And it was because of that, when I went and saw the endocrinologist in December last year, that the fact that I no longer had the retinopathy, or at least nothing serious, and I had also I'd put on weight again, and I'd had atrial fibrillation, and I'd had a stent fitted. All of those factors meant that it was a convincing enough case that I didn't even have to ask for it. She said, "I want to put you on tirzepatide. Is that okay?" Um, and I've been lucky in some ways to get it, but certainly for me, it's incredibly effective. Sorry? Yeah.
In a word, yes.
Yeah. Yes.
Yes. And I know because I'm on the diabetes board for Southeast London and Bromley, they will not be giving out any more Monjaro or Ozempic or any Wegovy or whatever type at this moment in time, even for type 2 diabetes, because they're so struggling to even give it out to people with obesity. It is because of the costs and everything else, but as I was speaking to somebody earlier today, they're very narrow-minded. They don't realise that the cost savings is far more than the cost of the actual Monjaro. There are people that I do know that are actually are getting it privately and doing quite well on it. But it's actually interesting. Excuse me. I was on a call a while ago for IMI about how Monjaro came about. Actually, it was actually through a trial called BEAT, BEAT, UK, where they were trying to find out various markers for kidney disease. And from that trial, they actually Lilly started to develop Monjaro. So just a sidetrack for you to a little bit extra information. And yes, Kathy, quite happy to talk about Sigma in any shape or form. But it is very much a very difficult area to, certainly in Southeast London, of getting any type of help with. Yeah, I will add one proviso that people need to understand that whilst these drugs are fantastic and even diets or whatever are absolutely brilliant, once you stop, that's when the real problem starts. If you haven't got hand to support throughout the time that you're actually on these things, then the chances are you will put the weight back on again. Reason being is our body remembers where we were comfortable with. And if we have a trauma, a stress or whatever, then we tend to end up going back to whatever made us in the first place in that area. So be mindful that it's not a cure, as Mark says. You have to work at it, and you have to work with it like having diabetes for the rest of your life, because it isn't a quick fix. There is no such thing as a quick fix. So unless you're getting the psychological support with it, then you're more than likely going back to where you were, or probably even worse. So
Absolutely.
So, be be very mindful of these sort of things. Oh, it's great. Well, I'll have this and I'll be fine. Yeah, you have to work at it.
Yeah, you do.
Do.
Sorry, Kathy, absolutely happy to talk to you. And if you specifically want to know about media studies on diabetes and the media, I may well be able to put you in touch with people as well. I'll have to get their permission first, but happy to do that.
I will DM Kathy later on with our Twitter handles, if that's okay, Ken and Mark.
Sure.
And then she can get in touch with us if she needs to.
Yeah, absolutely.
Yeah, or LinkedIn or Facebook.
Yeah.
For me, either. Those are also good.
Okay, will do. Well, my last question. There's been a lot of interest in the media and the press about celebrities and the general public using these weight loss injections and how this may cause availability problems for the diabetic community. How do you feel about this, and what do you think needs to be done to overcome these problems?
Yeah.
Or have I just opened the can of worms?
Actually, if you go privately, and I think they're actually trying to close this loophole of where somebody can just ask for it and get it. I know of somebody, or I heard a story, and this is a very true story of actually, all they had to do was show their weight and their feet on the weighting scale on the scales. What they actually did was actually got the heaviest weights that they could have and hang it on with them, so that they could get the weight going all the way up to a level that allow them to get the Monjero or whatever it was. Why do people do, especially the stars and everything else? The pharma companies love it because it is going to get their name out there, and that's good marketing for them and everything else. Is it helpful for the rest of us, those that really need it? No. However, it's all about the money. And the more they can charge, the better they're going to make in the profits, which is fine. I'm not against profit making. If somebody is taking it away from somebody that really needs it, that I really abhor in any shape or form. If you're a famous person and you need to lose about 2 pounds, then don't eat for a day. You've lost it, basically. But it's always going to happen, and we're going to always get these. Before it was the famous diets of every Tom, Dick, of Harry of some famous person. Now it's Monjero or Zempic or Wegovy or whatever. But we need less of that and more of quality of life, is what basically Tom was talking about. Because it's putting pressure on people that don't really need it, who think they need it because they're not the perfect body. There is no such thing as being the perfect body. I think we have to learn to love ourselves more and less of what we think we ought to be and be what we are. Because some people are naturally heavy and they will never lose weight. My problem is I have an underactive thyroid. Am I going to lose weight easily? No. So I think we need to look at how people view these things, and the media are the worst, I think, of actually exploiting how people are viewed in, oh, they've lost 10 pounds or lost 16 stone, yeah, or whatever, yeah. But they put it back on again. Most of them do. So how do we get around that? That is the question.
Let me know if you come up with an answer.
No idea yet. But you see where I mean. I mean,
Yeah.
Mark, it must worry you in a sense. What happens if you stop Monjaro? You know, do you have to keep going for life? Actually, you probably do. That's the trouble. Maybe in a lower dosage, but maybe you have to keep going.
Possibly.
We don't know.
No, we don't. I mean, I'm curious to know what's going to happen. My insulin usage has dropped so far from 120 units a day, roughly speaking, to about 20 to 25.
Okay.
And I've lost weight. I've halved my blood pressure medication as well. And I don't know where I'm going to end up with this. I don't know if I'm going to reach a point with my weight where carrying extra weight does reduce your insulin sensitivity. But actually, look, just this is the point that a lot of people don't appreciate. While in some cases it is possible that putting on weight will cause you to develop diabetes, in 95% of the cases, it's the fact that you have diabetes causes you to put on weight, because you have high levels of insulin in your system, and insulin is a fat storage hormone. So if I lose enough weight, will I reach a point where my metabolism ticks over to a slightly different path and I won't need the Mounjaro? I don't know. That'd be nice, and I'm certainly open to the possibility, but I'm not expecting it. Certainly not yet.
Yeah.
Ask me when I've lost another 10 kilos and I know better what my my diabetes is doing.
Yeah. Yeah, I think you're going to find that it is. Going back to Claire's question about A-listers and everything else, they keep getting it, keep taking it, and everything else because they need to be in that shape or form because somebody has told them that they are too fat, too whatever, and you think, really? Why are you being dictated by somebody else?
Yeah. I'm look, the only person whose opinion about me truly matters is the one that stares back at me in the mirror in the morning.
Yeah.
Totally agree with you there, Mark.
Yeah. That's the person that matters. How do you feel today?
Yep, absolutely.
Yeah.
And on that note, at 20 to 10, I think we'll finish and go on to the open forum. We were going to try and cover complications tonight as well, but we just got too much information going on the other subjects. So we will do the complications that we were going to talk about tonight on our next chat, which is the 7th of July, I believe.
I'll be here.
No, it must be the 8th of July.
Okay,
No,
it may be me just looking at the dates wrong.
No, sorry, it's me, the wrong month. Yeah, you're probably right.
Well, the 7th is a Monday, yes.
Yeah.
But thank you both for joining us tonight, and I hope the chat's been informative to everybody. Kathy, I have DM'd you, Ken and Mark and myself's Twitter handles. Please contact us and we'll see what we can do to help you.
Thank you for having us.
Thank you for coming. Anybody got any quick questions before we go on to the open forum? Nope. Okay.
Yep, you're welcome. It's a pity Helga would be with us as well, but I'm sure she'll be the next time.
I'll DM her tomorrow and let her know.
Yeah.
She did
Thanks for
send
having
her
us on.
apologies